Hello everyone, my name is Laurent SERVAIS. I'm professor of Paediatric Neuromuscular Disease at the University. I'm really sorry for not being here with you today. First because I love Hungary and Budapest is a fantastic city, and it's always better to be together and to have the opportunity to discuss. But you know, it's life, and I hope next year I'll be with you. So I've been instructed to give a talk about Duchenne muscular dystrophy and SMA treatments available, but not gene therapy. And you know, uh, uh, on top of that, I have to do it in 20 minutes, which is quite short, and no gene therapy, 20 minutes. I could not find an emoji that was strong enough to, you know, illustrate my pain about it. But, you know, again, that's life. To start with the most important, of course, I've got my fingers in many pies and several conflict of interest. Then came the question, should I start with Duchenne muscular dystrophy or should I start with spinal muscular atrophy? And finally, I decided uh, to do both diseases together. And I think it's interesting because then we can understand that the difference between these two diseases and how this will influence our therapeutic options. So, as you probably know, spinal muscular atrophy is a disease of the motor neurons, right? And Duchenne is typically a disease of the muscles, right? And this means a lot because motor neurons, the number of motor neurons that you have at birth is the same normally than the one you have at 60 years, right? At the age of 60 years. But muscle cells is not the same, right? Our muscle mass growth and the amount of muscle that you have when you are 3 years old is certainly not the same normally than when you are 60 years old. So we need to be aware that this difference of the evolution of the normal tissue in a human beings between the two cell types. The phenotypic spectrum is much broader in spinal muscular atrophy. It starts with the baby, it can affect the adults. Duchenne is supposed to be more homogeneous. It affects boys only. They lose ambulation before the age of 18 years old, and of course there is a milder form that we speak a little bit less about, which is muscular dystrophy. And then to continue the comparison about the gene, but I will not speak about gene therapy, but the gene is very different, right? It's a very small gene for SMA. It's a very long gene for Duchenne muscular dystrophy, and this will of course contribute to the difficulties of the gene therapy, but I cannot speak about gene therapy. And then the type of mutations are very different, right? SMA, it's nearly always the same mutation. It's a deletion of exon 7 of SMN1. And for Duchenne, there are several types of mutations. There are deletions, there are duplications, there are point mutations. So at the end of the day, it makes a much broader genotypic spectrum with, of course, consequences on the possible options. And finally, the other tissues, it's quite remarkable for spinal muscular atrophy then, except for the very severe cases, there is no central nervous system or heart involvement. In Duchenne muscular dystrophy, it's not that true, and we know that many of our patients have at the bare minimum a little bit, you know, of intellectual difficulties at school, and the most severe may really have autistic spectrum disorder. So, and the heart, by the way, is another tissue that is affected in the muscle in the Duchenne, which is not affected in SMA. So, two diseases that are very different, and as you might imagine, that will bring different challenges for therapeutic options. And finally, the incidence is about this. So Duchenne muscular dystrophy, what's new under the sun of Budapest? Well, first, we are making trials for years in Duchenne, and unfortunately many have failed, right? And there are still, you know, a pipeline of trials that are ongoing. And if I had to go through all these pipelines, I mean, it will take the entire talk. So I can only advise you, you know, to read the best authors, right? So recently reviewed the different, you know, emerging therapies for Duchenne, and another review, which is probably more funny and more interesting, is the one of all our failures, and we specifically wrote a review with Dora Marcati about all the failures that we passed through in Duchenne muscular dystrophy. So you probably know that the hot topic is the microdystrophin, and all you need is microdystrophin. Probably you've seen this in the chart with the four boys, golden boys, John Pfizer, Paul Sarepta, George Solid, and Ringo Genital, right? But I promised I will not speak about gene therapy. So let's speak about drugs at work. So here's a kid on the left side is before treatment, on the right side is after treatment. So we will ask him to go in the stairs.
Vas-y Wilson, sans la rampe, hein, au milieu. Hein. Ouais, super, continue, c'est bien. Continue, c'est bien. Encore, plus haut, sans la rampe.
Right arm on treatment. Left arm.
Eh bien, ok, très.
Allez, donnez.
So we all agree that this boy is on a treatment that works, right? This treatment is steroids. So this is a boy before and a boy after steroids. And as you can see, there is a dramatic effect of steroids. It increased the strength, it increased the power, and on the long run, it delayed loss of ambulation by 2 or 3 years. It reduced dramatically the risk of getting a scoliosis, and it increases the quality of life and the life expectancy. So something that works in Duchenne, something that has demonstrated to dramatically change the natural history of the disease is standard of care. A standard of care starts with multidisciplinary management and steroids, as I've shown you. We need to consider all the complexity of our kids. First, the cognitive issues. I think that we underestimate the difficulties of these boys at school, and I think it's double jeopardy to let them, struggling at school, because they have difficulties with the muscle. If on top of that they have to struggle at school, that's unfair. So some of them can really have attend normal school and have average results, but please do not undertreat the attention deficit in these patients. Take calf contractures. Splint may help. Certainly physiotherapy, stretching by parents, and surgery, but not so frequently. I mean, it's very rare that we have a real indication. When these kids will start losing ambulation, of course, the wheelchair, we need to check the back on a regular basis and consider spinal fusion in the right moment. And of course, this will be highly, related to respiration and the need maybe of a non-invasive ventilation, and maybe at one point a BiPAP. And unfortunately, sometimes we have to discuss a track, even if we don't like to go to track in Duchenne, to be honest. Of course, we need to be very careful from a respiratory perspective, to perform regular immunization, to treat any infection, and finally, of course, to follow closely the growth, the weight. And at the beginning, we try to break down because of steroids, they take weight, and then when they are 18 years old, we are trying to maintain the weight. So a good nutritional follow-up is important. You've probably heard about vamorolone, which has been demonstrated to be as efficient as prednisone and probably much less toxic on the growth and on the weight gain. Vamorolone is currently under consideration for approval. You've probably heard about givinostat, right? Givinostat that presents with a significant effect, about 1 or 2 points on the North Star. It's not magic, it will not cure the patients, but it can help. And it's a double-blind randomized placebo-controlled study. So this is also a drug that could be approved soon. No idea when, to be honest. And we have also all the exon skipping drugs that are available in the US, but not yet in You've probably heard about atrophy, which is an oral drug that helps to pass through the nonsense mutations. The evidence that it actually works is still a little bit controversial. Now there is a phase 3 that seems to be a success. It's not yet published, but with a minimal effect, right? We're talking about 1.5 points on the North Star over 1 year. So it's a small but maybe important effect on the long run. This is a study that compares the loss of ambulation, for instance, and in patients from a study and patients from a natural history study, but we need to be extremely careful because the natural history is actually in patients with all possible mutations, not only patients with point mutations. And this is actually the list of all the drugs that are currently in development. As I told you, for gene therapy products, but I told you I would not speak about gene therapy. These are the drugs that are actually approved today, and some of them are especially new exon skipping drugs in development. We were talking about Godelursin in this exon skipping drug. We need to be aware that the amount of dystrophy that is currently re-expressed by the with the use of the all generation exon skipping drug is quite minimal, and it translates into a benefit that we cannot measure before at least 3 years of exposure in this cohort, which was a small cohort of patients, struggled to reach the statistical significance. And that's why we actually need other exon skipping drugs. This is, for instance, a new PPMO from Sarepta, but we know that they are also Vertex using gene therapy, Wave Life Science now on exon skipping 53, Biomarine on exon skipping 51, Dyne, who has also started. So quite a number of trials that are ongoing in Duchenne. And then we have SMA, and SMA is a completely different story. We have 3 drugs that are approved, and 3 anti-myostatin. This slide is already outdated, so which are currently in trials. So the first drug that was approved and that is available now in spinal muscular atrophy is nusinersen. It's an oligoantisense nucleotide. It's injected intrathecally 4 times during 2 months and then every 4 months. I like to start with these slides because it's the terrible souvenir of a double-blind sham procedure control study in infants, in kids less than 7 months old affected by SMA type 1. And as you can see, yes, there is a strong difference in terms of survival, especially if these kids are treated early. And the earlier you can treat them, the better it is, and this is probably the best comparison between patients when you treat them before symptoms, before the age of 42 days, in terms of whatever they can, whatever the milestone, head control sitting, assisted walking, unassisted walking, the percentage of patients who attend this milestone is much more important than in patients who are actually treated after the onset of symptoms. And you know, I love to show this video, and probably many of yours have already seen it, of 2 kids, same family, same disease, but this young gentleman has been treated after the symptoms. We knew, thanks to him, that this little terror was affected, and we could treat the little girl before the symptoms, and this is the magnitude of difference. And the same kids 6 years down the line. Look, this guy is doing well. He survived. He is able to pick up a little toy from the floor, and he is quite a severe scoliosis. But the sister, who is treated with the same drug, which is nusinersen, by the way, and who is actually with the same disease, is doing perfectly well, right? And this is the magnitude of difference between the patients treated after the symptoms of the first. And then we have a second drug, which is the same kids 6 years down the line. Look, this guy is doing well. He survived. He is able to pick up a little toy from the floor, and he is quite a severe scoliosis. Gene therapy, but okay, I cannot speak about gene therapy, so I won't speak about gene therapy. It's a pity because I had nice slides, but okay, I will not speak about gene therapy. And then we have risdiplam. Risdiplam is an oral drug, right? It has been approved by FDA 2020, and we have quite a piece of data. It starts with firefish. The firefish is the patients who are actually with type 1, but we have also evidence in type 2 and in pre-symptomatic patients. To make a long story short, patients treated by risdiplam have a much better event-free survival than natural history study, and they continue acquiring new milestone during the second and the third year of treatment, and they continue to improve on the shop intent. And this is an example again of a little princess affected by SMA type 1, the typical clinical picture. And the same princess further down the line, she survived, she's better, but she's not ambulant. Obviously she's not. And to show you, this little princess was the same disease and the same treatment, but she has been treated before the symptoms in the clinical trial. And this is the magnitude of difference again between a patient who is treated before and a patient who is treated after the symptoms. And this is an example again of a little princess affected by SMA type 1, the typical clinical picture. And the same little princess further down the line, she survived, she's better, but she's not ambulant. Obviously she's not. And to show you, this little princess was the same disease and the same treatment, but she has been treated. We have several of the medications that are currently either under investigation, like anti-myostatin, either on off-label use, like salbutamol, like pyridostigmine, like sometimes aminopyridine, and some clinical trials also, with a very interesting one that was published recently for pyridostigmine. We've recently reviewed this different medication. So my take-home message is in SMA, spinal muscular atrophy, we have several treatments nowadays. They have clearly demonstrated their efficacy. There is no matter of doubt. But there are next steps. And the next step is, one, add-on therapy. With first line add-on therapy could be anti-myostatin. But we need to manage expectations, right? We know that our patients have a limited number of motor neurons, and that we can potentially improve them significantly, maybe, but not being transformative. And then we have also non-drug therapies, right? Like exoskeleton, like spinal simulation. And I think that we probably should pay more attention to whatever we can propose to our patients, which is not a drug. And more importantly, newborn screenings. I think that it's a no-brainer, an absolute no-brainer in terms of public health, in terms of patients' well-being, in terms of health economy. We've learned with SMA that when we have such transformative drugs, we need to be clever enough to use it the right way at the right moment. And then for Duchenne, we have drugs that are available, but that have a limited efficacy. And in the next generation of drugs that are currently in trial could potentially slightly improve the outcome. And I write slightly improve the outcome because I truly believe that we won't be out of the wood until we are able to bring full-length dystrophy on a regular basis. And that's because of the physiology of Duchenne. It's because it affects muscles, because these kids will grow. So everything that is one shot will probably not be enough because we'll have to give it early. But if we give it early, we will not be able to give enough. So we have a good potential now with all drugs that are in the pipeline to do better. But we will be out of the wood when we'll be able to bring full dystrophin on a regular basis. And this is not exactly for tomorrow. So there is still a lot of work to be done in Duchenne. We need to be aware of that. And I just want to finish this lecture. So I just wanted to finish this talk by acknowledging the work of my team, my clinical team in Oxford, the research team in Oxford, and the entire center in Liège. So I did it in 20 minutes, and I did not speak about gene therapy. Thank you very much for your attention.